Good afternoon, everyone. Thank you for joining us this afternoon. I'm Emma Best, and for those of you who haven't met before, I'm a London-wide Assembly member, and I'm the Deputy Chair of the Assembly's Health Committee, and I will be chairing today's proceedings. So chairing might be slightly elevated because I don't think there's going to be any fights. I think it will just be going through quite tamely, hopefully. We're all on the same page here. So thank you again for coming. We'll be focusing on the health inequalities aspect of the LGBT plus Commission, and more importantly, we're going to focus on solutions and recommendations regarding issues across the UK. So much of our audience here today are healthcare providers from local authorities, regional government, civil society, and we're very keen to hear everyone's perspectives on how you've approached issues in your organisations and your sectors. So during the conversations today, please do feel free to drop any comments into the chat. That's something that we can take offline and input into the inquiry, and also any questions as they arise, please also put those into the chat. As for the format, we're going to open with a statement from Dr. Michael Brady, the National LGBT Advisor for the NHS England, and then we'll be splitting this session into two halves. So in the first, we'll focus on healthcare and mental health, and on the second, that's when we'll talk about sexual health and fertility. So our first guest for the first half are going to be Dr. Ruth Hutt, Arfan Hanif, Dr. Ruth Hutt, who's the Public Health Director for Lambeth Council, Arfan Hanif, CEO of Touchstone, Dr. James Barrett, who's the Director for the Gender Identity Clinic, and Professor Jim McManus, who's President, Association of Public Health Directors, and also the Director of Public Health for Hertfordshire Council, which would make sense why you said you were in Hertfordshire then, Jim. So without further ado, I will move on and pass the mic, as it were, over to you, Michael. So good afternoon, and did you want to give us an opening statement?
Thank you very much, Emma, and thanks for the invitation to both join this afternoon session and also to say a few words at the beginning. So as Emma said, my name's Michael Brady. My pronouns are he and him. I'm the National Advisor for LGBT Health at NHS England. I also work as a sexual health and HIV clinician in Ruth's patch, actually, in South London. I work at King's College Hospital and also I'm the medical director at the Terence Higgins Trust. I was going to I'm not going to speak for too long, but just was going to frame what I was going to say around some of the priorities that myself and my team are working out on at NHS England, because I think they are three key areas that we all, as individuals and as organisations, policymakers, etc., should be focusing on to address LGBT plus health inequalities across the board. Just briefly, by way of background, my role as National Advisor came from the government's LGBT action plan. It was one of the commitments of the health section of the LGBT action plan, and my post was funded for a couple of years by the Government Equalities Office and now is funded by NHS England. And the three areas that I always kind of start these kind of talks about are data collection and monitoring, education and training, and delivering inclusive services. And hopefully we'll, I'm sure, pick up on some of those. And just to briefly say a little bit about each of those, we still, in terms of data collection and monitoring, we still, I would say, in healthcare and other settings, are really terrible at systematically asking questions about sexual orientation, gender identity, and trans status. We do have NHS England and NHS Digital, a national information standard on the collection of information on sexual orientation, which lays out how to ask those questions, and that has been helpful. So certainly across all of the NHS patient experience surveys and the staff survey, we now have been asking about sexual orientation for some years. That information standard is not mandated, which is one of the reasons why its implementation is relatively patchy. We've been asking these questions for a long time in sexual health and HIV services, but they do get asked in some mental health services, but not more broadly. And the absence of routine and robust collection of data on sexual orientation and gender identity and trans status means that We still don't fully understand the breadth and the depth of the inequalities that the LGBT plus community experience. We have no robust benchmarking data against which to measure any of the innovations that we put in place and to measure their impact. And I think also, particularly for trans, non-binary and gender diverse people, the absence of asking those questions is actually a way of services in the system excluding people from their services, by which I mean that if you're a trans woman or you're non-binary and you are employed by the NHS, or you go register at your GP, for example, if you're presented with two boxes that say male and female, and not a box in which you can identify your true self, you're already being excluded from that service, and that service is kind of communicating that you're not seen. So data collection and monitoring is the first one. Education and training is the second. The single commonest thing that comes back from experience surveys when LGBT plus people are asked, what would have made your experience better? Because it is almost universally, well, not universally, but is very commonly not a pleasant experience for LGBT plus people across the NHS. What would have made it better? And almost always the single commonest response to that is better training of the workforce. If only the doctor or the nurse or the receptionist or the porter that saw me understood a bit about LGBT plus health inequalities and was able to address them in the simplest possible ways. I use my name correctly, use the pronouns that I use, not assume that the same-sex person that's with me is my sister rather than my wife. So simple, I would suggest, training across the board, both at undergraduate and postgraduate level, embedded meaningfully in trust inductions and continuing professional development, and would make a massive difference just to make the staff more knowledgeable and have the skills and the confidence to support LGBT plus people more meaningfully. And the last thing is about delivering inclusive services. I think all of us who deliver services or who commission them or who write policies under which they sit should be giving thought to how inclusive really are these services for LGBT plus people. We know from a number of surveys that around 1 in 6 or 1 in 7 LGBT plus people will actively avoid going to services because they don't feel that they're for them, or they are and sometimes reasonably have an expectation of poor service or being discriminated against, which means that people, and I'd say particularly trans or non-binary people, but to a varying degree, everyone within that LGBT plus umbrella avoids going to services often, or delays going to services until what they've got is much more advanced, or they present more at a later stage. So inclusivities of services can be relatively simple. Sometimes it's just as simple as having symbols like rainbow lanyards or rainbow badges to demonstrate inclusivity, or posters in the waiting room that talk about LGBT plus organizations or promote screening for trans men. Simple signs that most people won't notice but do make a big difference to the LGBT plus community. And language as well is a really important thing, and imagery. The language and imagery we use in our patient-facing information and on our websites. We're certainly working with a lot of colleagues across NHS England and the system on gender inclusive language, which is really impactful, particularly in services that are very gendered, like reproductive health or sexual health services or gynecology services or maternity services. And the kind of language we use to describe those or to engage with those service users are not always inclusive of trans and non-binary people. So that was as much as I was going to say, hopefully just to set the scene. Those are the 3 areas of work that we're working on and encouraging the system to work on, and perhaps we can frame some of our discussions during this meeting around some of those. Thank you.
Thank you so much, Michael. You know, and so much of what you said, I hit home for me there, and I know somebody in the chat has already also said that hit home for them as well, because I should have mentioned, as well as being deputy chair of the health person, you know, I take this seat today as someone who has to take my children often to healthcare services with my wife, and honestly, it's a minefield, and trying to convince healthcare staff that you are their mother, you know, it's quite a chore, and honestly does take its toll. So yeah, that did really hit home. I'm just going to pass over now to go through our speakers, and I'd ask you all if you could be slightly brief in your comments, because the quicker we get to the chat, the more we can have kind of an inclusive conversation and put some of the audience's thoughts to you to get your perspective on that. So I'll start with you, Dr. Hutt. Ruth, if you wanted to take it away.
Thanks very much. And actually, I want to start just with an apology to everyone that still has to go into those situations and feels uncomfortable in them, because it's not right. And it feels really sad that after many, many years and a huge amount of work, actually, that we're still in that place. So a particular thank you to Dr. Brady and the work he's done. I think it's making a difference, but it doesn't happen as fast as we'd like it to. So I'm Director of Public Health in Lambeth. It's a very diverse inner London borough, diverse in every sense of the word. Apparently, we've got one of the largest LGBT plus communities in the country. Of course, we don't know that for a fact because you can't count or measure because of all the things that Mike's already said about data being such an issue. But we have also spent a long time at the sort of epicenter of advocacy, activism and allyship in the borough. We have, for us, developed a whole systems approach towards these issues of inequality, and we've got brilliant partners, and brilliant partners have enabled us to do work, I think, that otherwise would have been really challenging. But the sorts of things that we've identified, we've come a long way, I think, for gay men, probably in Lambeth. The experience probably is much better for them of health systems and health services, although it's not universally good. But I think we've got so far to come, particularly on trans health, and for people who are non-binary, sort of operating, and women as well. I think women don't always get a good deal. So we've done some work to try and set up programmes and committed ourselves as a council to working with services that we both commission, but also the NHS providers that we work with. And using our staff, we've got a large contingent of staff actually who are very active in this, both through their own lived experience or through allyship, that can really help us shape services, understand what the experience of those services is, and feed it back and hear stories. The power of people's individual stories, particularly when people aren't aware of their own unconscious bias and how they discriminate, and how that discriminate manifests both in terms of experience but health outcomes and future health behaviours, is so important. Particularly for us, intersectionality becomes important. We have communities where there are still quite a lot of religious or cultural beliefs, which makes it quite hard to be you in those communities, and actually providing support from a wider community to enable people to feel safe to be themselves, or to find safe spaces or places or ways to work with their family community, are incredibly important. And our staff, of course, reflect our community. So sometimes those prejudices are also held within our staff. So the training and access we give to staff to support them through that and understand the impact that has is so very, very important. I'm very proud that in Lambeth we've got Clinic Q that's making quite a big difference, I hope, to the health and well-being of people in the borough, trans people in the borough and more broadly across South London. And also the Pride and Practice programme, which is very much geared at primary care, so GPs, but also extending to pharmacies, because these are often the front line of where people first encounter some of those bad experiences, which then impact on how they use our system. We've done a bit of work on understanding the impact of the pandemic on our LGBT communities. But again, to Michael's point, none of the COVID data has recorded that sorts of information. So whilst we can talk with a fair amount of confidence about what's happened in certain ethnic groups within the community, we cannot do that for people with other characteristics. And that's a real shame, actually, that we're in that position now. So we rely very much on surveys. But I'm really keen to stay involved and engaged in this space and hear the comments and questions, because I do feel there's a lot we can do to make this better.
Thank you very much, Ruth. Really good. And I was just in a health committee meeting actually the other week with Pride and Practice. They were talking about the work they do in your borough, and it really is fantastic. And if we could roll that out further across the country, that would certainly be a massive improvement. Moving on, if I could, to Arfan, Hanif of Touchstone. Arfan, did you want to give some opening thoughts?
Hi there, everyone. I'm Arfan from Leeds. I think the first starting point is the importance of allyship. The burden should never be placed on the people who are being oppressed, who are being discriminated against. So I'm of a Muslim Pakistani heterosexual identity, but my rights have been protected because I've got allies. So the burden should never really be placed on people who are being oppressed. So allyship is really, really important. I'm the CEO of Touchstone, and we're a mental health service provider which operates in West and South Yorkshire. And we provide a number of mental health services across the board, from the preventative community development side right up to working in hospital wards. And we serve about 10,000 people. And the comments from the previous speakers do resonate, because one of the first things that we do as an organisation is identify the nature of our service users. And just giving a figure, and this is a case study from Touchstone, of the 10,000, we have around 7% which are LGB. In terms of non-binary, trans and other gender diversities, we have about 3 dozen service users. But in terms of intersectionality, we also have about a third Black minority ethnic, about a half which have indicated a disability, and also about a quarter which have indicated which they belong to a diverse faith community. Now, the key thing here is about representation, and there's no equity without representation. And until you get data, you won't really have a sense of urgency. People talk about financial commitment, then we get the evidence for that. But when we talk about evidence around equality, diversity, inclusion, and so on, we don't tend to have the evidence. So it's important that that data gives us that sense of urgency. Now, for Touchstone, the starting point is always to create a safe and accepting and inclusive culture, regardless of the type of mental health services that we provide. Of the 250 staff we have, over a quarter are LGB. 6% of our staff have indicated that they are non-binary, trans or other. Over a third are Black minority ethnic, and over a quarter come from different community faith backgrounds. There's this important intersectionality. It's about creating inclusive, safe, accepting places for all groups, regardless. And as part of this, we have training programs on LGBT awareness, trans awareness, but also things like Islamophobia, anti-Semitism. It's part of an overall package, and it needs to be part of this overall inclusive culture going forward. And as part of the training, we also give opportunities for staff to join various groups. So we have an LGBTQI staff group, we have a BME worker staff group, and we're in the process of setting up an interfaith staff group as well, recognising some of the intersectionalities that we have. We also have service users, which are consultants that we pay, and half of which currently are LGB. So the first starting point for us is to ensure we always have representation. And this sort of comes out in terms of the evidence in terms of service delivery. We have a trauma-informed approach to service delivery, where we recognise some of the additional challenges certain groups face around discrimination, bigotry and hate. So based on some of our data, what it suggests that if you're LGBT, you're more likely to end up in crisis. And you're going to bypass all the preventative services. So that is a concern. Why is a demographic group ending up in crisis, or more likely to end up in crisis? So whilst we've got 7% as an overall sort of profile, when it comes to crisis services, it's well over 10%. So there's a concern in terms of what's happening at the front door. What we've also identified in terms of intersectionality is that where service users are predominantly all white, there's a high concentration of LGBT sort of service users. But where we've got services which are exclusively for Black minority ethnic, or more likely to be, there's a lower proportion of LGBT. So there's issues around intersectionality, about safe places for people who might be Black and LGBT. In terms of reflective points, I think if you don't have the data, then there's no real sense of urgency. So that's really important. And if your workforce is not representative, then it doesn't matter how good your strategy is on paper. You need to have a workforce which is representative so that people feel that it's safe for them. I think there needs to be a better understanding when it comes to service design to recognise some of the intersectionalities, to ensure that certain groups are not excluded. And from experience, I think there should be more investment in community-based mental health. We shouldn't have members of the LGBT community more likely to end up in crisis or in hospitals. So that's the lesson. from us, from Touchstone in Yorkshire.
Thank you very much, Arfan. And moving on to Dr. James Barrett as well, I'll just say again, thank you for those that are putting their comments in the sections, in the comment section, and Arfan, just some really positive feedback on Touchstone for you there, if you wanted to check on that. So yeah, saying that you are walking the walk, not just talking the talk on intersexuality. So James, I'll pass over to you.
Thanks very much. I tend to be quite interested in solutions, and I'm not going to give a kind of big run over of what my sort of service looks like generally. Instead, a statistic, some bad news, and some good news, and a bit of a story, really. Start with the good news. It used to be extremely problematic for the kind of trans and non-binary folk who arrived at our services, because very, very few clinical commissioning groups would fund fertility preservation for them. And this was kind of struck me as slightly ludicrous, in that you can have a kind of fit, well, healthy, happy, 23-year-old young trans woman who would make an ideal parent for somebody, losing her fertility because the NHS won't pay the few £100s to preserve it. And at the same time, if you're a convicted paedophile in prison and develop cancer, you've got an absolute right to have your fertility preserved. And this is terrible. The solution came actually from a commissioner. Commissioners can be wonderful people. Jeremy Glyde, who's the commissioner for gender services. I remember it well. It was at a clinical reference group meeting. Said, well, why don't you go to the Equality and Human Rights Commission? They don't hang around. I thought, brilliant suggestion. We discussed it afterwards and thought, God, he's right. So we did, and there was a lawsuit which settled out of court, as these things do. And now we're in the position where that's almost universally funded for trans people. So change can occur sort of quickly sometimes. Often it needs that spark of brilliance, this occasion from Mr. Glyde. The remaining difficulty, I suppose, are things that don't require money to fix with fertility. It is the persistence of clinical commissioning groups muddling up fertility preservation with assisted fertility, IVF and so forth. They're two totally different processes. Trans people are just in the same boat as everybody else for assisted fertility. Fertility preservation is a different process. And some of the clinical commissioning groups haven't yet kind of realised that, and we have to keep reminding them of that lawsuit, and it's rather tiresome. For healthcare for trans people, I'm not in the least way going to talk about the healthcare provided in gender identity clinics, because it's part of specialist commissioning and it's something that is being addressed. I'm far more interested in the bulk of trans people, and those are people who are through services and out the other side, and they're just kind of getting on with their life. Because just like everybody else, they get ill, they get injured, they need the kind of routine maintenance for their kind of gout and glaucoma and stuff that everybody gets. And in that context, their transness, as it were, isn't important and doesn't need to be raised. And it can be particularly problematic and unpleasant and sometimes dangerous if it is. A chief difficulty for lots of patients is actually changing their registration. And if is there anybody here who in any way who has any connection with government, please hear this. Please, can the Passport Agency helpline stop telling callers that they require to get a gender recognition certificate to change the sex marker on their passport, when the actual website of the Passport Agency has a little bit within it, advice for transgendered applicants, which begins, you do not need a gender recognition certificate to change the sex marker on your passport. We spend an awful lot of administrative time with upset patients on the phone saying, I can't change my passport because I need a gender recognition certificate. And we even have on our website the bit from the Passport Agency's own sort of website that says you don't, and yet the advice line still says that it does. That would cost nothing to change now. So could somebody please do that? The statistic. There is an awful lot of kind of concerns about, not from anybody on this Zoom call, I wouldn't have thought, of the terrible dangers that might be posed by people who make a change of gender role in order maliciously to find their way into women-only spaces and assault them and so on and so forth. This might sort of cheer everybody up. The number of people who've been through the clinic I lead since it opened in 1966 is, I calculate, 130,000. Of whom 100,000 are trans women who are just sort of getting on with their lives. We also hear whenever any of them goes into prison, because by and large the prisons can't handle their hormones, and ring us for advice. And doing the calculations, I have worked out that it is mathematically, statistically the case that you are literally more likely to be sexually assaulted by a member of parliament than you are by a trans woman. So let's kind of concentrate on where the dangers are, I think. And the last one is a story of where it can go wrong. And this is somebody who I know well because I remember him from 10 years ago, and I'm going to call him George, although that's not his name. George was a trans guy who went through our services and out the other side and was living very, very happily somewhere in England. And he had had a phalloplasty, so he had a penis. He hadn't had his, where the urine comes out had not been redirected so it went through the penis, so he still sat down to wee. And he got on with his life fine. I was contacted by his wife, who said he had blood in his urine. And he went to his local casualty department, as you do with these things, where they persistently addressed him as Miss and insisted he had to use the ladies' toilet to provide a urine sample. And this was a guy who was getting on with his life like any other bloke, with nobody being any the wiser. This was immensely distressing. Eventually they called the urologist, who said, "Oh, I'm not sure where we'd admit somebody like you." So he went home because he couldn't stand any more. He was summoned for a rigid cystoscopy, and when he arrived, found there were 14 nurses to attend his rigid cystoscopy. And when he asked why they were there, they said, "We were told to come because we'd never see somebody like you again. And so it's a chance to have a look while you're anesthetized." He then went home from that, unsurprisingly, and eventually I got into contact with his GP, his wife and he were really upset. He went to a different, better hospital. But unfortunately, you see, blood in urine is painless, is one of the symptoms of bladder cancer. And bladder cancer is one of those cancers you want to get early. And I received the saddest email of my life towards the tail end of last year saying that George had died. And his wife was very upset, obviously, but grateful for the assistance that we had offered when he was at the clinic, and also in attempting to get him some kind of healthcare after he had left. So there are perhaps places where we can still go, I think.
Thank you,
Enough
James.
from me.
Thank you. And what a wonderful background as well, there's commenting on, I think. And I think, yeah, I think especially the points I pick up there is so often we know things have already happened. There's already rules in place that are just, you know, it's with the passports, it's very much with NHS services and things that NHS staff can do. And so often it's just that lack of training or communication on the front line of staff where things completely break down. I'll just pass off finally to Professor Jim McManus. Jim, for some comments to you, and then we've got a raft of questions that we will try get to many as possible from. So Jim, over to you.
Thanks. I'll be brief. So I'm president of the Association of Directors of Public Health, and very proud to have Ruth as one of my peers and one of my colleagues. And in Hertfordshire, where I do my day job, we also have a number of other initiatives. What I'm going to say is I think that we need a public health approach to this, which is, there's a surprise for a public health person. And the Association of Directors of Public Health is the body which represents the professional voice and judgment of directors of public health. This is not a body that represents our own individual viewpoints, it represents our professional judgment. And what I did in advance of this session was I consulted a number of DSPH, so LGBT plus DSPH, DSPH with LGBT plus populations and families and loved ones. And I've put together a very brief paper on some priorities that you're very welcome to have and to use. It seems to me that we have more than enough evidence of the impact of homophobia, discrimination, stigma. Call it, you know, we could go on forever identifying the things that harm LGBT plus lives. And we have more than enough evidence of health needs and impacts. And, you know, some of the pioneers of the health field are on this call. So if I may single out Catherine Meads, for example, who has advanced almost single-handedly, I think, the research agenda by moving into the field of systematic reviews. We know that there are some things we can do, and there are some things we need to do. And to that end, I think we need to actually realise that there are a range of factors that can be considered determinants of poor health in LGBT plus populations. Just as we know that in poor populations, being unable to afford decent food can predispose you to cardiovascular disease, so in LGBT plus populations, exposure to stigma and services that don't want you, you know, for example, the whole issue of people with HIV trying to find a dentist, for example, just as one example, and the eloquent and rather harrowing example that James gave, can predispose you to worse health than others. We need to really have a concerted effort to try to eradicate that from public policy. I think there are several problems with public policy. One is that it is siloed. And a second, I think that British public policy on health has really been too much about clinical care for the last 40 years and not enough about other factors. And while we have made some advances in LGBT plus equality, actually many things remain to be done. I'm going to suggest, I think, 6 priorities, and I'll type these in chat when we've finished. I think the first thing we need to do is actually articulate in detail what a public health approach to LGBT plus health means across the life course. And by life course, I mean conception to grave. And that in itself can be problematic if you have a very heteronormative approach to life course and you're dealing with trans people. James's example, for example, spoke very eloquently to that. You need standards for policy actors and standards for services, from NHS and care services right through to education and housing and employment. And I want to just give 4 examples of this very quickly. We should have a very clear policy ambition that every single person, including every LGBT plus person, reaches adulthood confident and safe in their identity, their inalienable dignity, and their contribution to society, and with good mental health. That means from the early years, and Ruth and I commissioned things like health visiting and school nursing, we need to have health visitors and school nurses who know what that means for all children, not just the assumption that all children will be heterosexual. The second example is that every person has the best disability-free life expectancy and good mental health into older age. And LGBT plus people do enter older age with more avoidable disability and more avoidable life-limiting illness, be it physical or mental, than many others for all sorts of reasons. That should be a policy scandal. The third example is I think we do need to ban conversion therapy. If nobody has seen it, Haldeman's book, which is finally published this month from the American Psychological Association, fantastic summary of the evidence and the case, if you can actually get your hands on a copy, because it hasn't arrived in the UK yet, and I've had snippets of it. We do need to ban conversion therapy. It needs to be gone from all sorts of use across the life course. At the same time, I think we also need to address not just organisations and inclusion, but the way in which some organisations have developed LGBT leadership. We've developed leaders to be heroes and trailblazers, and then supported them, and are rather surprised when they develop avoidable mental ill health or trauma or burnout or stress. and as someone who's a psychologist, I have a particular interest in this field. The model of LGBT leadership as heroes building a healthy organisation really needs to be consigned to the doesn't work and it's harmful. And I'll give a link in the paper to a blog on that piece. So those are just 4 examples. To move on with the rest of my 6 priorities, my second priority would be we need to systematically counter the invisibility of our population's policy and planning. And that is about thoroughgoing data collection and analysis and transparency in statistics. But one of the biggest problems here, we have to face this, is the culture of the NHS and the culture of services in collecting data. The lessons from collecting ethnicity data alone should tell us that actually this is not about just collecting data, this is a long haul. The third priority should be that we have to require policymakers, planners and commissioners to systematically include our populations in the planning of public services. It's a sensible obligation. It moves beyond the obsession that we still have in some aspects of diversity policy with individual protected characteristics. The fourth one is I think we do need to encourage all health and care professionals, especially those professionally registered, to address and respond to the needs of LGBT plus service users that they encounter inclusively and to do the amount of learning. Racism isn't acceptable, nor should it be ignorance of people in all their rich and wonderful diversity. My fifth one, and forgive me for rattling through these, but I want to get this done within 5 minutes. I think we do need to increase funding for research in LGBT plus health and its impact on public policy. One of the great riches of LGBT plus researchers is that they're very highly skilled, for the most part, in multiple methods. And actually, they've pioneered methods that are now being used elsewhere in health research. It's about time we got the National Institute for Health Research to do more on this, I think, and within this to increase the opportunities for people to become researchers and especially people from our populations to become skilled. And finally, I think my sixth priority would be we're a bit rubbish in this country still at dealing with multiple diversities. We tend to be good at dealing with perhaps one and not the other. So if you're disabled, you know, for example, and Christian or Catholic or Muslim, and I could go on, we tend to focus on one individual protected characteristic rather than being truly responsive to the multiple aspects of people's lived experience and diversity. And we won't have LGBT plus health, I don't think, not equal health, until we've actually made some impact on these 6 priorities. So that's what I would offer. Coming out of the pandemic, we've got some research on the experience of Black populations during the pandemic. We haven't got very much on the experience of LGBT plus populations. We need it, but I do think we need to sit down and make a concerted effort at a 10 to 15 year approach of systematically improving this, because this is a system-wide problem and it needs multiple interventions by multiple actors at various places. It's not just a public mental health issue, but it's a public health issue. So I would conclude and say that just as there is no health without good mental health, there is no public health without good LGBT plus public health. And I'll stop there and thank you for listening.
Thanks very much, Jim. And can I thank all the speakers again for making their comments solutions-based. I think that was very informative. And if we could continue the rest of this first half of that discussion on that basis, I think that's going to be really helpful. So I'm going to kick off questions. Going back to Michael, we've got a couple of NHS-focused questions. I think perhaps we'll start with you there. So we've talked a lot about data. So one of the questions we've received from Professor Catherine Meads, Professor of Health at Anglia Ruskin University, is why is it that the NHS is still not recording patient sexual orientation in any useful way to be able to link to hospital episode statistics, in spite of the ONS validating a questionnaire measure of sexual orientation 12 years ago. And there's another question as well, which I'll put to you at the same time, about how we use the pilot schemes will be used to change NHS gender clinic procedures going forwards.
Okay, thank you, Emma.
Sorry, just to say that was from Arthur Webber, sorry.
Thanks. I was trying to have a look at the comments and the questions coming through. I mean, to answer the first bit about why do we still not have a systematic collection of sexual orientation data, one of the answers to that is in the chat somewhere, because the sexual orientation information standard is not mandated. Now, mandating things across the NHS, I would love it to be mandated personally. Mandation, though, doesn't necessarily mean that you will suddenly go from no data to some data. And I think, this data collection monitoring is probably the single biggest area that me and my team are working on. And I always split the approach into two things. There's the practical infrastructure things, which are supported by useful information standard, whether they're mandated or not, and infrastructure such as IT systems that can actually enable people to record the questions in the way that we want to. But we've also got a really big piece of work to continue to work on, which is about hearts and minds. Staff need help and support to feel confident to be able to ask the questions and understand why the questions are of use, and patients and service users need to have confidence on answering those questions completely and understanding why we're asking those questions, and also how that information will be used. So I think mandating it and putting it in a contract is potentially one of the solutions, but isn't going to be all of the solutions. And actually, to be honest, we're focusing more of our work on the hearts and minds stuff rather than the infrastructure stuff. Those questions are continually being asked, and the situation may change. And just to answer another brief comment on that, is that about gender identity, trans status information standards, we are just starting the work on doing that, because at least having a centralized document that has a standardized way to ask the questions is a starting point, whether or not you mandate it. In terms of the second question, which I didn't see, and I'm going to try and remember, which I think was about pilot clinics for gender identity services. I'm perhaps not the best person to answer that question. I don't work in the specialised commissioning department at NHS England where those pilots are being commissioned, but I am a member of the programme board that hears updates on that. What I would say, and we're waiting to see the initial evaluations, but from speaking to trans people who I see in our sexual health clinic in South London who have accessed one of those pilots in Dean Street, the anecdotal feedback that's coming back from those pilots is almost universally positive. Personally, I think that those models of pilots are the right new model that we should be moving from. Away from an overly specialised model, and one which looks at different models of care in different settings and delivers that in an evaluated way. So I think as the pilots grow and we learn more from them, that hopefully that will be the direction of travel. But certainly what I'm hearing from people who are using those services is very positive, and we look forward to seeing more formal evaluation as time goes on.
Thanks, Michael. And Jim, you wanted to come in on this?
Yes, if I may. I mean, there is a huge and extensive literature on implementing health policy change, and it strikes me that the whole area of diversity is one area where that literature has been lacking in use. For example, so the Health Foundation has done some significant work on LGBT access to cancer treatment and a variety of other things, but there's a huge literature on why policy changes don't get implemented. The biggest single factor is culture. Another factor is that your systems are rubbish, and a third factor is actually just the amount of policy priority people put on it. Bear in mind, we still haven't got 100% ethnicity data recording from the NHS, and a report was published this morning on severe school absence by the Centre for Social Justice that used data from 2020. So all data to make a policy point for today, and actually that data was out of date and it was impartial and incomplete anyway. So I do think we need to do much more about implementability and the implementation. There's a huge field out there that we need to take from social scientific studies of healthcare and health management through to the kind of healthcare quality work that's been being done. And I think that offers us a lot. But the reason we don't get traction is because actually I think we're not systemic enough in the policy ambition and grounding it enough. If NHS England really made it a priority to collect this, things would change. And I'm sorry if that's a rather jaded view of things.
Thanks, Jim. A comment that's quite concerning there in the chat says standardization of changing gender on NHS records is needed. Lots of trans people have had it done differently, including people who have had entire new records created, losing their entire previous medical history. Come to James next on that. Yes, I can see you preempted the hand. And James as well, also somebody asked a question on fertility funding and when those changes were made earlier in the chat. So if you could address that as well, that'd be great.
Name change, sex change, first of all, on NHS records. It is possible for people to commence a brand new NHS record with a brand new number. If you do this, you lose all your previous record. If you're 19 years old with not much in the way of health history, that may not be the end of the world. If you're 57 years old with a complicated medical history, it could be a bit of a disaster that if you're found unconscious being shipped into a casualty department in Droitwich, nobody knows anything about you. As it is possible to change the sex on somebody's record whilst maintaining the integrity of the record, but most GPs don't seem to know that, or that if they do, they assume that everybody will want a new NHS number. Incidentally, if you are going to go for a new NHS number and a brand new record because you're very concerned that people don't identify you as a trans person, the time to do that is when you've finished any treatment in gender identity services, or otherwise your brand new record is going to begin is attending a gender identity clinic, which may not be quite what you're after. Another sort of more weird point is some GPs seem to think that changing a name is the same as changing the sex on the record. It is not. Some GPs persistently don't even change a name, but just put down prefers to be known as, which is not the same thing at all. And lastly, and weirdly, some GPs seem to think that all trans folk want the style of address MUX, MX. Now, some might, but often there's no choice. You go to your GP and sort of, say, I'm going to commence my life living as a woman, and you're just sort of given this title. Weirdly, without any kind of option over it. Now, if that's what you want, great. If a new NHS number is what you want, great. But people should know the consequences of having that, and that they have every right to have whatever style of address they like, provided it's not one which is fraudulent. So you can't, for example, call yourself, sort of doctor or professor or something unless you've got a chair and a PhD. But for Mr. and Miss and Ms and Mux, interestingly, Mrs. and so forth, these aren't titles. A title is that which in law denotes rank, privilege or training. Everything else is a style of address, and as such you may style yourself just exactly how you wish. It's like sticking Esquire after your name. It looks all grand and that, but any bugger can do it and it doesn't mean anything. So banks as well are prone to saying, oh, you can't possibly sort of change from Mr. to Miss, it's your title. No, it's not. It's just a style of address. I can style myself Mrs. if I want to. I just don't want to.
Thanks, James. And just say there was a question in the chat there on lockdowns and the relation with HIV and breaking the chain, but we'll come to that one in the next session. So I don't think I'm ignoring that. Fertility funding. That was the other one, wasn't it? Yeah.
And
then, James just say that.
I will put in the chat when that guidance came out. Can I display a document on this? Do I get to share screen in any way?
Hal might be able to drop you a line on that. I'm not sure.
If he does, I'll quickly chuck it up on the screen so that people can see it.
Okay. or perhaps he can have a little chat with you in the
Yeah, sure.
region whether that can happen. And if I move on, so there was another question in the chat on the importance of inclusive language, perhaps in healthcare systems, and looking towards the panel. Perhaps Arfan, did you want to come in at all about the importance of inclusive language? Or I see Michael. Yeah, come on.
Yeah, I just wanted to references to the NHS and collecting data and a sense of urgency. There are public duties. There is a legislative framework, if there was leadership for some of these bodies, to collect this data. So we're a charity, yet we collect this data. And what we find, we're in contracts with our NHS colleagues where they've got a legal framework, which they don't. So there is a framework which brings some of this together. However, people don't use it. There are duties on the public sector. So it's concerning that a charity does that, whilst organisations where it's referenced in a piece of legislation, they don't. So I think there needs to be some reference to the existing legislation to the public bodies. In terms of inclusive language, obviously that needs to be across the board, and it starts off as an employer. As I said, as an employer, we can control things, but when it comes to service delivery, it's difficult to influence. So we just need to ensure, in order to get this language, inclusive language, you create that tipping point in terms of your employment representation, where people can speak like certain, so I can say certain ways to an Asian person that a white person can't. So it's about representation when you use inclusive language. I can't say certain words to the LGBT community, which they might say to each other. So it's about creating that representative workforce when it comes to inclusive language. But my real point is there is existing legislative framework behind this. It's been there for quite a few years. And there was the amendment out of race relations years ago, which created some of these duties where actually there's a legal duty for these bodies to publish the monitoring data, not only to collect it, they have to publish it. So I've got concerns as a charity that we do it and our statutory colleagues don't.
Thanks, Arfan. And whilst I'm with you, I'll come onto a question submitted by Debbie Laycock from the Head of Policy and Public Affairs at the Terence Higgins Trust on how we can ensure that we are also considering intersectionality and the multiple layers of health inequalities that exist. For example, LGBT people from ethnic minority communities, something you talked on at great length earlier, but I don't know if there was any final kind of comments on the solutions there that we need to make clear at the end of this session.
I think it's the point what Jim said, treat people like human beings. I've got various identities. I've got gender identity, I've got sexual orientation identity, I've got an age identity. They come at different points. They're primary at different points in my life and who I go with. So it's recognizing the human beings, and the point here is about human rights. I think that word's not been used, I think, during the discussion, that human beings have certain rights and they have certain identities. And we're fortunate that we have such a diverse human family and different identities. So that's the way I see it. And I do agree with Jim, let's not categorize human beings.
I found that document actually, which I can share. Oh, host has participated, disable participant screen sharing.
Yeah, so I think something, just message Hal privately and see if there's a way to get that across.
It was the date for if anybody's interested is April 2019, and it's formation of clinical commissioning policies for fertility preservations, guidance for CCGs. It rattles on a bit as documents do, but at the end says specialist endocrinology services, rare mitochondrial disorders, and endocrine treatment or surgery for the alleviation of gender dysphoria. I'll email it to Hal if anybody wants it.
Thank you, James. And Jim, did you want to come on that very briefly? Because I've got a few questions here I want to get to Ruth as well.
Yeah, very briefly, if it's okay, just on the kind of issue of intersectionality. There's lots of research out there, and I hesitate to talk about research methodology with people who've written and forgotten the book on this, but in the room, know better than I. But we know that if you engage and involve people in research about services that affect and impact on them, you get better outcomes, better quality, and better research and better policy. So one of the things we need to do is, if we're going to do work on intersectionality, we need to engage communities in a much more systematic way when research is funded. And I think that's a real key thing in health policy that we've seen for years. The more you involve research in services about people, the people that they're about, the better results you get. And I think that's why I'm kind of arguing for this sort of real systemic population approach to what we're doing or what we need to do.
Thanks, Jim. And just say there was a helpful comment there, I think, from Jane in the comment section around the need for banning conversion therapies for all ages, including the most common form, which is in religious settings. So yeah, thank you for that, Jane. I think that's well noted by the panel. And just a quick few questions to you, Ruth, if that's okay. Firstly, wanted to ask, what opportunities and barriers are there for integrated care systems to address LGBT health inequalities? And as well, it would be good to understand what's working well in Lambeth in engaging with primary care practitioners and what success there has been to date. Obviously, I've just recently become very familiar with the Pride in Practice work, but perhaps I want to share some of that.
So actually the Pride in Practice work, which has been running now for a few years in Lambeth, is a great example of something that the ICF could get behind and involved in for the rest of South East London and the country, in fact, and other places are doing it as well. Pride in Practice is a way, originally it started working with primary care GP practices, but it's been extended to pharmacies, and also we're looking at how we might use it with BCS organisations, which talks a bit to this issue of intersectionality as well. I think we've got a lot of groups across Lambeth, faith community groups, which could also really benefit from some additional training. There's probably a lack of knowledge, insight, a bit of ignorance around some really pretty basic stuff that can be addressed through a bit of people sharing their story, understanding different perspectives, and we found that quite powerful. And what we've also started to do through some of this work in Lambeth is bring together some of the work we did with Black Thrive, which is around mental health experience of the Black community, with LGBT plus type sort of programs of work, so that we are bringing learning from different bits of our community together and adapting it so that it's culturally appropriate in our setting for those people. So use of things like emancipation circles, different things that have worked for particular groups, which has been really well received, but testing it all back, so you're involving the people who are impacted, as well as creating more allies as you go on that journey, and sort of seeing how that plays back in people's experience. In terms of ICSs will all have some responsibility around health inequalities more broadly, and this is another inequality that we need to pick up and address, made worse in many situations by the intersectionality that also occurs in that. I think there's a lot of good practice that's out there already, so championing and learning from the good practice, because whilst the overall picture is not overwhelmingly positive, probably there is some amazing work going on, and actually the profile of that work I think needs to be lifted much higher, and particularly where you can do things at scale, and learning from the experiences of services that have managed to do things right. And there's plenty of them. You don't have to hunt too hard, but I suspect that there's a bias to particular parts of the country where they probably have better access to some of that. So ensuring that access is more widespread, I think, is important. And going back to this point about how you measure it, and at the moment we very much rely on surveys to sort of give us some of that feedback. We do need to have better ways of collecting the information, but people need to feel safe to divulge it. They need to feel safe to divulge it to their employers if they work in these organisations, but they also need to feel safe when they're receiving care, that actually if they offer that information up, or they're asked for it and they offer it, that it doesn't impact on the care they receive. But there's something important about asking it as well, because when you're asked about yourself in that way, immediately it becomes a bit more inclusive, I think, and if you can open a conversation by having those questions, actually people might feel more able to share that information. Certainly we found that in the past in other things we've worked on, including in HIV and other places. If you actually ask the questions, actually people feel safer and more confident to divulge that there and share their information. But I think certainly there's lots of work and lots of things that we'd like to put through to the ICSs to actually make sure that this is pretty high up their agendas too.
Thanks, Ruth. Just one more, a question from Julian Pascal Saudi, who maybe you know, he's a counselling psychologist in South London and Maudsley. But he's asked about the idea of an LGBT plus consultation hub embedded within traditional mental health services. Is that an idea that you've thought about, or would you have any thoughts on that?
So locally in our South London, the Maudsleys have actually done quite a lot of work around this already, and they do have specific mental health support services available. I don't know that they go quite that far, that they're sort of embedded in terms of any particular research function or anything else, but I do think that there is work going on. I think the challenge is people don't always know how to access it. And if your first point of access is through your GP and your GP doesn't know about it, or even if it's direct access and you don't know it's there, then actually it in effect is not accessible. So there is something about making sure that that information is widely and freely available to people. In Lambeth particularly, one of the commitments we made in the whole systems work we did was to make sure that young people, school-aged children, were really aware of what their options were if they wanted to go for specific support or felt that they needed support from somebody who understood their LGBT status or their experiences, to try and enable people to go on that journey. But again, there are issues, I think, that it's not available everywhere. So how you can direct people into that provision or reach out to them and sort of pull them into it if that's what they need is really important as well.
Thanks, Ruth. So what I'd like to finish this first session with is just to come back to all our speakers, and this only works if you are very disciplined, and give it just a maximum of 30 seconds listing as quickly as you can your top 3 solutions that you want to see as part of the recommendations of this inquiry. So we'll go back to front and start perhaps with you, Jim.
Well, I'll be very brief in under 15 seconds. Take a public health approach, start and address the 6 priorities I've suggested.
Brilliant. Thank you, Jim. And moving on to James, please.
Sort out the infuriating administrative glitches of the sort that I've outlined, and include an obligatory part on the training of medical schools, nursing schools and kindred things, where it's not all, where trans folk are not seen somehow as with the same issues as gay and lesbian folk, because it is really rather different. One of them is who you go to bed with, and the other is who you go to bed as. It should probably be taught separately and should be taught full stop, which it isn't at the moment.
Thank you, James. And Arfan.
My 3 are workforce representation across the health system of all groups which live in our society. The second thing is monitoring. Not just monitoring, we move towards an intelligence-led sort of policy agenda. And the third point is investing in community-based mental health services. Let's invest downstream. And what's best for the community is services that are delivered in the community by the community. So those are my 3.
Thank you, Arfan. And Ruth.
So I think training, absolutely training as mandatory training across the board for everyone. I think co-design and engagement from our LGBT plus communities in services, how services are developed, how they're evaluated and their impact, and data, to be honest, how we measure what's important, and doing that in such a way that we can actually track change and improvement.
Thanks, Ruth. And finally to Michael, over to you. And as well. Cheeky last question as well there. That, is there an NHS strategy to improve GPs' knowledge of transgender health? So perhaps you could answer that one quickly as well.
Okay, in 30 seconds, I'll try not to be repetitive because I agree with what everybody else has said. It's got to be, the foundation has got to be data collection and monitoring. We should not do anything without meaningful engagement and consultation, co-production with the community. And I think, as everybody to some degree has said, we've really got to have a sea change in terms of education and training, and change the hearts and minds and cultures of those who are delivering care. In brief answer to the, is there an NHS strategy to improve GP's knowledge of transgender health? I'm not sure if there is an overarching NHS strategy, but certainly my team has a strategy to do that. We're working on a number of projects which will support, I think, all of the issues that have been discussed here: better gender identity care, and also the more general things that James has touched on, just being better and nicer at looking after all of the healthcare needs of trans and non-binary people, which for the vast majority of cases is actually nothing to do with their gender identity, and is everything to do with their general health and mental health and well-being problems that we all are at risk of.
Thank you very much, Michael, and thank you to all our panellists for a really engaging hour of discussion and evidence into this inquiry. As always with these sorts of events, an hour, or any amount of time will never feel long enough. But Hal and Ben have put all the email addresses that you need there into the chat to supply evidence to the inquiry. And obviously, the conversation goes much wider than today. So please do feed into that, because this is really just one tiny part of that discussion as well. So apologies as well if I didn't quite get to your comments or statements, but we have got a large audience today. So once again, just to thank the panels, apart from Michael, who's staying with us again for the next hour, but thank you to all of you for joining us for this first part of this session. It was lovely to meet you. Thank you. And I will give a moment for a new panel to hopefully magically virtually appear. And I think we have everybody. Perfect. So for our second session today on the health inequalities, we're moving on to sexual health and fertility. And we're joined again by Dr. Michael Brady, the National LGBT Advisor for NHS England. We have Deborah Gold with us, who is the Chief Executive of the National AIDS Trust. And we have Megan and Whitney Bacon-Evans, who are LGBT plus fertility equality activists. So again, starting with you, Michael, if that's okay, to just give a little introduction into this session.
Thank you. So I'm speaking in this session, I think, with my many hats on. So I don't know if people have stayed from the previous session. So I won't repeat the broad introduction that I did with my National Advisor for LGBT Health hat on, just to reintroduce myself for other people who've joined since the earlier session. I'm Michael Brady. My pronouns are he and him. I'm the National Advisor for LGBT Health at NHS England. I'm also talking with my hat of a sexual health and HIV consultant at King's College Hospital and Medical Director of the Terence Higgins Trust. For those of you that were here earlier, I mean, we were talking very broadly. Well, I started off talking very broadly about some of the key components to addressing LGBT plus health inequalities, and those three components I do think are relevant to the sexual health, HIV and fertility discussions we're going to have now. It's firstly the absence of good data collection and monitoring that covers all sexual orientations, gender identity and trans status across our systems, so we can understand the communities we serve and address their health inequalities. It's training and education for the workforce so that they can meaningfully and empathetically look after all LGBT plus people and understand their specific needs. And it's true delivery of inclusive services that recognises the full range of sexualities and gender identities and meets their needs within those services. So did you want me now, Emma, to do my STI thoughts as well? Yes, there's a little nod. So I was hoping that I wouldn't go first, because there's probably going to be a bit of overlap between what I'm going to say and what Deborah and Whitney and Megan are going to say. So I'm going to try not to steal their thunder. I mean, the reason for that is that the way I think about sexual health is that it's all encompassing, and it includes STIs, prevention, treatment, management, but also includes contraception, reproductive health, fertility, cervical screening, and massively obviously overlaps with HIV. But I'll try and stick just to my brief, because it's going to be very focused on STIs. And just a few things that I wanted to raise as I think key issues for the LGBT plus community. So if we're thinking about sexually transmitted infections, the disproportionate impact of STIs, particularly gonorrhea and syphilis, on gay, bisexual, and other men who have sex with men, we need to do more to address that. We're still seeing significant rises in STIs, as I say, particularly syphilis and gonorrhea, and in a concerning environment of potentially increasing gonorrhea strains which are resistant to traditional treatments. So to address that, we need to be sure that our services are equitable and accessible, and we are able to meet the needs of gay, bisexual, and other men who have sex with men, both in terms of face-to-face and online services. I think we are probably dealing now with a double whammy of a cut in funding to services that happened some 5 years or so ago, and then COVID, which we probably still haven't fully recovered for, and the sort of complete, pretty much absence of face-to-face services and a shift to online services. I'm a great and massive advocate for online services. I think that they can meet the needs, online STI testing, HIV testing, of a wide range of people, and I think we need to make sure that they're equitably available across the country. And that was one of the challenges that we found when COVID hit and face-to-face services shut down. There are some parts of the country that don't have as good access to the portfolio of services, you like, that includes online as well as face-to-face services. But our STI work needs to be meaningfully integrated with the other determinants of poor sexual health and the other service providers that work in this area, by which I mean predominantly mental health, drug, alcohol, and other substance misuse. And when we're thinking about gay men, particularly those services that support people engaging in chemsex. We talk a lot about gay men when we talk gay, bisexual, and other heterosexual men when we talk about STIs, but I think there are others within the LGBT plus umbrella that are too frequently forgotten. Young bisexual people, I would say we have good data that shows that particularly young bisexual women are at increased risk through riskier sexual behavior, higher reported rates of STIs, higher reported rates of chlamydia, and higher reported rates of unplanned or teenage pregnancies. And yet we see very few health promotion or services targeted particularly at young bisexual people, and particularly young bisexual women. Trans and non-binary people are frequently absent in our health promotion and in our considerations around service provision. We've recently done quite a lot of work at Terence Higgins Trust to develop some online resources around sexual health written by and targeted at trans and non-binary people. I've seen other data that show very low levels of knowledge around sexual and reproductive health for trans people, high reported rates of teenage and unplanned pregnancies, and low reported rates of contraception use, low reported rates of cervical screening. And yet we have very few targeted services for trans and non-binary people. And I deliver one in partnership with Clinic Q at King's. We might come on to that a little bit later, and very little targeted health promotion specifically at that community. I'm not going to say anything about PrEP because I'm sure Deborah is going to say something about that, but that's key for the LGBT plus community. So the last thing that I just wanted to say is about not forgetting the important role that education plays in this space. Now, it's good that we have mandatory reproductive and sexual health education in schools, but I would suggest need to do more to make sure that that is truly and meaningfully LGBT plus inclusive. At Terence Higgins Trust some years ago, we did a survey about reproductive and sexual education, which showed that a tiny minority of people, and certainly this was my experience, but it was many years ago, got sex education or relationships education that was LGBT plus inclusive. And we need to make sure that now that we have put that into law, that schools are supported with the right resources, with the right amount of time, with high quality face-to-face dedicated time for teaching, using quality assured materials, and making sure that Ofsted has a strong role in regulating that. I'll stop there.
Thank you, Michael. And I think those points, especially around education, are so important. And now we have the law in place, making sure it is done appropriately. I mean, I'm embarrassed to say, but I think it does need saying that I was in my 20s before I realised that I needed to be concerned about my sexual health, because I was taught about sexual health in the framework of heterosexual relationships. And so, you know, it's so glaringly obvious that that is where the changes happen. And I've seen in some secondary schools, they're doing this fantastically, and in others, not so well. So it is the big point going forward. Just moving over to you, Deborah, welcome to our second session.
Hi, thank you.
Go ahead, the floor is yours, sorry.
All
Sorry.
right. Well, hi everyone, I'm Deborah Gold. I'm the Chief Executive of National AIDS Trust, the UK's HIV rights charity. And I'm just going to apologise. I had loads to say. I wanted to get myself organised, so I'm slightly reading just to make sure I kind of get stuff out in order. But I want to talk to you about some key issues we need to see movement on to increase equality of human rights for LGBT plus people living with HIV or at risk of HIV. And this bit of the meeting of the agenda includes fertility and sexual health, and that's really helpful for me because my issues intersect both of those. So I'll be touching on some progress that I think we need to see to ensure we reach the target of ending new cases of HIV by 2030. And some improvements and opportunities for improving the lives of people living with HIV. But first, I want to talk about the way the current law discriminates against those living with HIV who want to access gamete donation, that is same-sex, people in same-sex relationships who want to have a baby using a surrogate by implanting an egg in their partner, or where an egg or sperm donation is from a known friend or relative living with HIV. And so the current code of practice published by the HFEA, which licenses fertility clinics, states that a gamete donation from a person living with HIV is prohibited. And the impact of that policy is that it has a negative impact in 3 scenarios. The first is surrogacy. So a gay male couple, either with different serostatus or both living with HIV, who wish to use a surrogate. The second is co-maternity. So that's a lesbian couple where one is living with HIV and wishes to have her egg implanted in her partner. And the third is known donation. So a person who wishes to receive a gamete donation from a friend or a relative living with HIV. In all of those scenarios, that donation wouldn't be allowed under the current HFEA rules. And by contrast, the policy doesn't apply to a heterosexual couple who have different serostatus, where they require fertility treatment. And that's because neither is treated by the rules as a donor. The woman is not transferring her eggs to anyone else, and the man's sperm is partner donated, which means it doesn't need to be quarantined in the way that the rules currently state that a donor's would be. So whenever an egg is transferred from one woman to another, or whenever someone gives sperm to someone who is not their partner, that gamete provider is a donor under those rules, and the donor can't be living with HIV. I'm sure, I assume most of the people kind of on this call will be aware of the accepted science that confirms now, and has really for many years, that there is no risk of someone living with HIV passing that HIV on sexually to someone else if their viral load is undetectable. And that means that assuming that the donor has an undetectable viral load, none of the scenarios I just listed carry with them a risk of HIV transmission. And so our position, alongside that of a range of other organisations and experts we've been working with, is that as long as all the parties have the relevant information and they provide informed consent, there's no scientific or ethical basis to justify these rules, and they need to be changed as a matter of urgency. And you'd think that would be relatively simple to do. The science has changed. They just need to see the science, change the rules, but no. In the last couple of years have shown anything at all, is that it's not easy to get it to change. And just before I kind of explain, I want to say this is not theoretical. We've been working with people over the last couple of years, and we're working with somebody now who's kind of currently being affected, and I'm sure there are many others, through not being able to use these services. So the we started by speaking to the HFEA, and they state they need a request from the Department of Health and Social Care to change their guidance. So we went to the Department of Health and Social Care, and they state that they received their scientific advice from SABTO, which is the Advisory Committee on Blood and Tissue and Organs. And SABTO have reviewed the latest evidence without using an HIV specialist, misunderstood the science, and concluded that risk continues to exist. And despite a letter signed by over 35 experts, including Beaver and Bash, challenging their interpretation, they stick with it as we are now. So our position is that the Department of Health absolutely must require SABTO to urgently reconsider the science, using HIV experts to advise, and they need to do that soon. And if they don't, we at National AIDS Trust, alongside allies, will need to consider our next steps, and that includes legal action. This is obviously discrimination, and it can't be allowed to continue unchallenged. I mean, we're really delighted that on World AIDS Day last year, the government published its long-awaited HIV action plan, detailing in broad terms how it plans to reach the goal of functionally ending new cases of HIV by 2030. As part of that plan, it accepted some challenging new targets, which were set as part of the Independent HIV Commission that was sponsored by National AIDS Trust, Terence Higgins Trust, and the Elton John AIDS Foundation. And we really welcome that, alongside a partial rollout of opt-out testing for HIV in emergency departments in high and very high prevalence areas. The plan is currently pretty absent of detail, and so the next really crucial phase will be that includes identifying targets, timelines, and of course resources. And we need to see progress on some other key gaps. As Michael mentioned, like one of the key things for us, you know, we really welcome the now national rollout of PrEP on the NHS. It took a lot longer than it should have done, but we got there. But its availability is limited to sexual health clinics. A genuinely equitable PrEP service would make it available in places where a wider range of communities go, and that will help to deal with the fact that at the moment there is inequity in terms of who is accessing PrEP, and so that includes places like GP surgeries and community pharmacies. The action plan is pretty vague on how it's going to make that happen or whether it's going to make that happen, and there are no resources available for that. So that's a key area where we'd like to see some movement over the next couple of years. And then, sorry, it's really hard to narrow these things down, but my final thing is, you know, well, nearly final thing, it's never going to be possible to make real and final progress on the fight against HIV without also making progress on pervasive stigma and inequality that is baked into it. HIV stigma, maybe it has a different shape to the way it looked 20 or 30 years ago, but it absolutely still persists, and it's inextricably linked to homophobia, transphobia, and racism, all working together to drive the epidemic, and meaning that progress is not seen equally by all groups. So, you know, as we've seen with COVID, HIV disproportionately impacts on communities who already experience inequality, not just in terms of protected characteristics, but also in terms of poverty, migration, other issues. And genuinely, finally, this time, I just want to briefly talk about the challenge and the opportunity that some of the recent changes in the health system offer. HIV is one of the conditions whose health pathway was completely broken by the 2012 Health and Social Care Act, which split responsibility for prevention from responsibility for care, basically removing all financial incentive from inside the system that would usually exist. Because for HIV, a saving is realised by the NHS where HIV is prevented, but the spending is made on prevention by local authorities, which have seen their public health budgets cut enormously and disproportionately over the last 5-10 years. So, I mean, it's enormously disappointing that even the impact of COVID wasn't enough to convince this government that investment in public health is absolutely necessary, and that is a huge travesty. And the changes that are going through at the moment around developing ICSs, the regionalisation of HIV, means that the government has a real opportunity to improve the way things work. One of those things, for example, could include issuing guidance around better cooperation between the different parts of the system. There's been like a relatively warm reception to some of our questions on this, but we really want to see some real commitment to that now. And I'll stop there.
Thank you, Deborah. And just say, got a lot of people in the chat there thanking you for bringing those up and articulating those points so well. Really frustrating on the equitable equal fertility, and again, you brought up the opt-out testing. Obviously, £20 million now from government, but like you say, it's got the spending of that. It has to be right, and it has to actually reach the right targets to be effective. And again, just quickly, the point on the public health and the reduction of the public health budget, whilst in terms of the NHS budget, it's not equitable. Looking at, you know, preventative along with reactive. That's, you know, I used to work in children's services, and so always make the argument for where that money is saved on preventative services. Thanks, Deborah. And finally, moving over to Whitney and Megan, thank you so much for joining us. My wife actually told me about your campaign very early doors, and then I started seeing you guys everywhere talking about fertility equality. So thank you very much for joining, and I will pass the floor over to you.
Thank you. Firstly, thank you so much for having us. We are honoured to be here. So just to briefly introduce us, I'm Megan Bacon-Evans.
And I'm Whitney Bacon-Evans. And we are wife and wife.
We're also content creators. You may have seen us more in the press recently for being LGBTQ+ activists around fertility equality. We've been together nearly 14 years, and we embarked on our baby journey at the beginning of 2020, and that's when we basically discovered barriers in place, which we're going to run through now.
A rabbit hole, if you will. We presume that as we are a legally married couple, that as a family, we would be also viewed equal in the eyes of the law. But that appears to sadly not be the case. There are many barriers in place, as well as a great lack of knowledge and awareness that we found.
Mm-hmm. Firstly, the system is out of date. It is looking at fertility in terms of medical infertility, as opposed to non-medical infertility or being socially infertile, if you will, which mainly obviously applies to LGBTQ+ people who, no matter how much we try, we cannot create a child together naturally. And then this leads really into the unfair financial burden that is placed on the LGBTQ+ community when it comes to the eligibility criteria in receiving funding on the NHS. And this is where we've been in the press recently, because we currently do have legal action against our CCG about this, which we can go into later. And what this relates to is essentially the postcode lottery in England, where different clinical commissioning groups, CCGs, give different funding to different areas, and this results in different levels of funding treatment for fertility treatment. This applies to the LGBTQ+ community and the heterosexual community. However, where this impacts on us more is when we are required to self-fund artificial insemination in order to receive treatment. So, for example, majority of CCGs do require same-sex female couples to self-fund between 6 and 12 rounds of artificial insemination. For example, our CCG actually requires 12 rounds, thank you very much. And what that actually means within that is that 6 rounds have to be self-funded in a private fertility clinic. Now, if you all don't know, fertility treatments are very expensive. So in forcing same-sex couples to pay for private treatments, you're actually making people spend between potentially £25,000 to £50,000. The unfair financial burden is quite clear there. And in contrast, heterosexual couples, their requirement is 2 years of unprotected sex, but at no financial cost. And obviously we do know infertility has its burden and its emotional toll, but there is no additional financial cost. There's also no evidence required. You know, they don't make you have a little diary or evidence it in any way, but we have to make sure we go to the clinic and self-fund 6 rounds or 12 in order to receive treatment. This also, there's like this onus on medical infertility. Obviously, as I've said, we can't create a child anyway, but we still have to prove it. And then if we actually already knew we were infertile in the sense of we had polycystic ovaries or something else, medical condition, we still have to self-fund. We still have to go and pay thousands of pounds to prove that we are infertile, even though we know we are infertile. It's just crazy. And, you know, we've had followers tell us that they were told by the GP if you were straight, you would receive funding straight away. And they like to refer to it as lifestyle choice as well, which is nice, which, no, thank you. Yeah, so that's my little part for that bit. On to Whitney.
And also, we initially, when we embarked on our baby journey, wanted to do home insemination. We thought that sounded like a lovely idea. It could be a nice intimate setting, and we weren't forced into such a clinical environment. But we found out that because we got our sperm from a sperm bank, that there was a ban on home insemination since 2005 from sperm banks specifically being shipped to the home. So due to this, well, this is actually in relation and coincides with sperm donors being anonymous since 2005. They can no longer be anonymous. So this therefore forces LGBTQ+ people to use private clinics if they want to access safe, medically screened sperm or risk, more dangerous routes. You know, not everyone can afford expensive fertility treatments, and there are many online groups of men also offering their services, you know, free of charge, if you will, and that can open up, you know, many dangerous routes as well. I mean, there are some, you know, good, genuine people, men who, you know, do have right intentions, but that's sadly not the case for all. So, and often these men, sometimes they will prey on women's vulnerability because at this stage they are going to be very vulnerable, and they often know this. So furthermore, you know, if you were to draw up a private contract as well, this won't stand in a court of law. So meaning that the known sperm donor could actually fight for the rights to the child in future, which is very scary. So this financial barrier, alongside the ban on home insemination, pushes some into debt and others into very dangerous situations, or just giving up on being able to create a family at all, as they're never going to be able to meet the criteria to receive help on the NHS, which is very heartbreaking and sad.
There's also a great lack of knowledge and awareness from GPs, for example, to start with. For example, for us, we rang our GP for advice. Where do we start? Because there's great lack of awareness out there on how we even would go about starting to create our family as a same-sex couple. Unfortunately, our GP did not know. He asked around the surgery, no one knew. He came back and said, well, surely you would receive the same help as heterosexual couples because that would be discrimination. I'd say you would think so, but don't know. So that was really frustrating. You know, we thought we might get an answer from our GP, no idea. We went on our CCG website, no information anywhere, like could not find what applies to us, how many rounds do we have to self-fund. In fact, we had to do 2 freedom of information requests to find this out, which was all very frustrating, let alone finding out what the requirements are, then being more frustrated. But just to say, Stonewall, the UK's LGBT rights charity, have actually just recently launched a postcode lottery tool, which is amazing. So you go onto it, it'll be on their website, and you type in your postcode. It then brings up a lovely template to send to MPs. So a lot of you may have received them recently, where it automatically will say what treatments are required for in your area, and you can then email your MP to say, not good enough, thank you very much. So that is very awesome, and we're hoping that everyone will start doing that. So please do go and check that out and check out what your area is, because you might not have a clue. Some areas do offer self-funding, so there are a few in England that do offer self-funding straight away, which is lovely. And then this has been touched on already slightly, but there's also discrimination in shared motherhood or reciprocal IVF, which is, say, you know, if Whitney wanted to carry my child, we wanted to swap eggs, I'm treated as a donor, but I didn't know that about HIV, so that's very interesting as well. But not only am I treated as a donor, I actually have to pay for that. I have to pay to be a donor, I have to pay for the screening, even though it's just going to my wife. So that's just a completely ridiculous step that's involved, and it's not included for heterosexual couples if they are doing the same. Obviously, when a man donates his sperm to his wife, that's what he's doing. But when it comes to a same-sex couple, they make you be a donor. And you know, we've received messages from followers who've already spent thousands and thousands, and then they've now been told they need to spend an extra 2,000 just to be screened, even though it doesn't matter what the results are because your wife still wants to carry your child. So that's just absolutely awful, really.
So yes, we have a petition to create awareness. It's reached almost 8,000 signatures, which is great. And there's also a similar petition that's reached almost 55,000 signatures as well. And as Megan said, we've also taken legal action against our local CCG as well.
Yeah, at the moment it's been issued for a judicial review, and we are waiting for the outcome on that. So there's a lot of information there, obviously, and there's a lot of things that we'd like to see happen. Firstly, you know, we want the government to do a review into the fertility sector, in particular focusing on the ban on home insemination. I think would be a really good start, because that's putting people, you know, forcing them into dangerous situations, as well as debt by having to obviously go to the clinic if you want to get sperm from a sperm bank, which is obviously a great route. And we also would like for the NICE guidelines to be reviewed. These are the guidelines that CCGs follow, and while they're not mandatory, you know, we'd like for them to be reviewed and looked at. And Baroness Liz Barker has already raised this in House of Parliament, and they've said that the NICE guidelines are outdated, which is brilliant, and they're being reviewed as far as we're aware. So that's great, but that's just something I want to say. That's what we want, so thank you very much. We obviously would like for the postcode lotteries to be looked at within that as well.
And as mentioned prior, we want to, it would be nice to see data being officially collated with LGBTQ+ families and people who are applying for access to fertility treatment, because there is just such a lack of data. Full stop.
Yeah, but within that, for example, we were told by the doctor, you know, you're often told when you go for treatments that IUI is not as successful as IVF, which could be the case because of the different levels of treatment. However, data isn't being collected or separated, if you will. So obviously heterosexual couples going through IUI may have other issues that need sorting out in order to get pregnant. Us, for example, we may have no other medical infertility issues, and therefore this kind of the data is getting skewed, and lesbian couples are getting told IVF is way more successful, IUI is way less successful, and you know, so a lot of people will just self-fund straight to IVF as a result of that as well, because there's no point spending thousands and thousands on IUI if you're just going to have to go to IVF, because you're probably not going to get to the point where the NHS steps in, let's be honest, really. And then finally, we really would love for there to be formal training for all NHS staff. It's been raised before, but you know, we hear a lot about how people are treated. I mean, Emma mentioned it as well, and it's just, you know, we get asked with sisters daily pretty much anyway, but in a medical setting, you know, you really don't want to be disregarded as the mum. You know, people get asked who's the real mum, but who's the dad, all those kind of questions are just really invalidating, especially then when you have your actual child with you who is like, what, that's my mum, what are you saying that for? And another thing was, it's just very simple, is forms. Yes. Because when we were going through the route, you know, finding out information from the NHS, when we had our fertility consultation with the doctor, they sent us a form that included a whole section for male partner, and I was also told on the phone, just disregard that area, just don't worry about that. I'm like, can you not send another form that actually applies to me? It's not that hard to just do a separate form. So essentially on that form, completely ignored that I had a partner, that Whitney existed, and that was just, you know, really disappointing and disheartening. Yeah. And that's the end of our
thank you very much. Thank you guys so much. So I think what we'll do is stick with fertility for now, and then come back to our conversation on sexual health afterwards. There are a lot of comments on in the chat after that. There's a lot that I can relate to, obviously, with, like I said, the forms and just the general comments from NHS staff. I expect, you know, being in a same-sex couple with 3 children, to have some people be slightly new to that, but outside of the NHS. But when I go to the hospital or doctors, you know, I would expect them to not ask some of the questions that we get asked. The first question there from Catherine Mee, or comment, is around the policy on home insemination pushing same-sex female couples to use IVF through special financial deals at private clinics. I know that's certainly what I had to do, rather than the donor insemination they actually need. So that's at one point for discussion. Someone saying about ovarian hyperstimulation through egg harvesting. Somebody else has asked Whitney and Megan if you have got a view from the Equality and Human Rights Commission, though they're not so popular in the last few days. And the current policy of IVF rates going up, probably as in relation to that rule. Lots of comments there. I wonder, perhaps I'll give you a chance to read those as well. Maybe Michael, if you wanted to make some comments on this, and then perhaps I'll come back to you, Whitney and Megan.
Oh, okay. Well, first of all, thank you, Whitney and Megan, for sharing your story, and also for your campaign and your activism. It's welcome, and I wish you all the best in that. Listening to the story, which I've heard a number of times before, and I'm sure people will acknowledge hearing it, it just seems like such a no-brainer. But anyway, good luck with everything. I don't have much else to add, because I think Whitney and Megan have said it so perfectly, but just that thing about the forms just really struck me, because that's something that I'm banging on about at the moment, and it just requires, I mean, it feels like it should be so simple and so straightforward, and people just to be a bit empathetic and thoughtful. I was sent something similar recently by a trans man who'd been sent a letter from their GP recalling them for cervical smear that was all chatty and friendly, and said, "We ladies live very, very busy lives, but find time to pick up, come in and have your smear done." And it's just so thoughtless. So well done you for banging on at that and just challenging them. And I'd encourage everyone to challenge, because it should be easy to change. But I didn't have anything else specific to say, so let me not steal the time from other people to ask questions.
Thank you, firstly, for your compliments. That really means a lot. In answer to some of the questions, no, I don't believe the Equality and Human Rights Commission have weighed in as to whether it's discrimination or not. Obviously, we have an amazing law firm. We're working with Lee Day and barristers Jude Bunting and Marlena Valles. And they're all amazing and obviously all agree with us that it's discrimination. So, but we haven't heard from EHRC. And yeah, with the egg donation, so yeah, a lot of couples are being encouraged to donate their eggs so that it'll be obviously used by other couples who are needing egg donation in order to receive cheaper fertility treatments. This might not be something that a couple necessarily wants to do, but they might be feeling that they're forced to do in order to be able to afford the treatments in the first place. So essentially, they're kind of being made to create other families, which some of them may love to do, but we've had messages and people say that they didn't want to do it, but they felt they had no choice, which is really quite sad as well. And that someone said their local MP replied the nice guidelines has begun, which is excellent, good news. Yes, that's what we're hearing. So yeah, I don't think there was really any other.
Another question here submitted privately from Jamie L. Brin, saying, what is the NHS currently doing to help LGBT couples who cannot afford private fertility treatment? So I suppose what might be a nice is there anything that you've encountered which has been good practice, which could perhaps be stepped up, escalated,
yeah, sorry, yeah, I did forget to mention that. So while there are some CCGs in England that give funding, also NHS Scotland, for example, gives funding regardless. And what this mainly normally is 6 rounds of funded IUI, which is like artificial insemination. If that doesn't work, they then fund 3 rounds of IVF, and I believe the cost of donor sperm is also covered. So donor sperm is very expensive, by the way, like £1,000 for a vial. You need that per round, and you may have many rounds. So you can imagine that easily adds up. So yeah, there are a few CCGs that are doing the right thing. Even within our own CCG, we fall under 3 policies. For example, in our area, requires us to self-fund 12 rounds, but down the road, they do give funding to same-sex couples. So yeah, it's been done, and it is possible.
And Wales do it as well, so it's just interesting to see the clear divide between England, Wales and Scotland. So it is very much possible. We just feel a bit behind the times here.
You used to live in Wales, so
she is so well.
So there's really some clear recommendations here, and it's quite easy to look across to the other NHS in Wales and Scotland and see how this can be done much more equally.
Oh, sorry, just one thing I forgot. We didn't mention gay men and the fertility that they have to go through, and obviously they have to go through surrogacy, which is very, very expensive. But because we just obviously can't speak on their behalf, we don't include it as much. But when we do speak about the requirements, that's for us, that also applies to single women and also trans men or individuals with wombs as well. So it doesn't just fall under female same-sex couples, it is the whole spectrum. Yes, apart from gay men, sadly. Well, not sadly, but don't want everyone to be subject to it. But
there's something really quite disheartening there from James in the chat about speaking to a trans man who was taken on and told nobody would want eggs from someone like you. Really, really sad. Another point had raised for a question here is there is a growing body of evidence informing LGBTQ+ people that are more likely to suffer health inequalities with accessing care, and particularly when it comes to maternity and perinatal services. So I suppose the wider picture, I don't know if anybody wanted to come in on.
I couldn't hear that, sorry, I don't know if it was just me. But,
no, yeah, I lost you a little bit as well, Emma. You went a bit fuzzy.
Sorry, the inequality on when it comes to maternity and perinatal services. So throughout the journey, perhaps, of pregnancy or conception, after conception.
Was that about trans men particularly? I could talk to that because we have.
About the Yes, but also about the wider community as well.
I might go first if I may, just because it's a little bit of a shout out for a piece of work that we have been working on at NHS England called Items, which is focused particularly on trans men and non-binary people assigned female at birth. Items is a clever acronym for which I take no credit, which is the improving the experience of trans and non-binary people in maternity services. And it was funded by the Health and Wellbeing Alliance and undertaken by the LGBT Foundation. And I mention it because we have a report that's going to be published in the next few weeks by the LGBT Foundation, and we'll be holding a sort of roundtable virtual meeting if people want to come along. The main, I would say, headline, well, a bit of background. It's part of the work was a literature review, part of the work was a survey of trans men and non-binary people assigned female at birth that had used maternity services in England, and there were, I think, 125 responses to that survey, and that makes it the largest survey of its kind in Europe and the second largest of its survey of its kind in the world, which also speaks to the great lack of evidence in this space. There's a lot of data in there, but the single point I would draw to your attention is that 30% of the respondents to the survey gave birth without accessing any antenatal or perinatal care, NHS or private. 55%, I think it was, said that they would like to have had a midwife or other person involved in their care, and I think 80 or 90% said that they didn't choose to do that because they didn't feel the services were inclusive of them, or they were concerned about having a bad experience or being discriminated against, or had previously bad experiences. So we know that we don't actually have data on how many cis women choose to birth alone, but I think ONS says that about 2% will have home births, and a lot of those will be people who've chosen to have home births and who will have antenatal care to support them. So 30% is massive, and speaks volumes about the challenges in that area. So it's called Items. Look out for our we'll be hosting a webinar, and the LGBT Foundation will be publishing that report in the coming weeks. And one of the other things I just wanted to briefly say is about the importance of inclusive language. We touched on this a little bit in the previous previous session. Services which are traditionally very focused on women or cis women frequently do not use language that is inclusive of everybody who might need them. I either want everybody who has a cervix or everybody who has a uterus. And we're doing quite a bit of work on setting some guidance and some policy, starting with maternity services, but that will broaden out to other services where it's relevant, on the use of inclusive language. And I would recommend, and I'll put a link in the chat if I can find it, if you're interested in reading more about this, there is a great project at Brighton and Sussex University Hospital Maternity Services who have done a really great piece of work on gender inclusive maternity services, and they have dedicated gender inclusive midwives at that setting, and have a very sensible and inclusive and additive approach to language. So it's just to make that point about the importance of inclusive language in clinical settings, to encourage people to use services who perhaps are not using them. I'll put a link to the Brighton work in the chat.
Thanks. If I could just come straight back on there, because Ash in the chat has just put a comment saying, I'm a trans non-binary student midwife, and inclusive language is hotly contested on the ground. I really hope a policy change from above can make the difference. But what is it that will create that change in your mind? Because obviously we know, how important inclusive language is, but what's the how there to make sure that it's widely accepted on the ground?
I think, as is it Ash? I think, as Ash had said, it's leadership. Those of us that are in positions of authority or power influence have to set the culture from the top. And I think it's also about a committed leadership that is willing to challenge what is often a very toxic environment and debate around this. The concept of inclusive language often gets sucked into the debate around trans rights and where you are sitting on the trans inclusive or gender critical spectrum, and often people will talk about the erasure of women, or the woke nature of people wanting to call it something else and not call it maternity, and erase the use of the word women, which we certainly are not doing, and those services who have done this successfully have not done either. It's that kind of point that, you know, these rights are not a zero-sum game. You can support and communicate with cis women whilst at the same time using language that is inclusive of everyone who has a womb or has a cervix or who needs those services. So the Brighton work, for example, will use language like woman and other birthing people, or woman and other pregnant people, or women and other people with a cervix. So it's additive and it's inclusive whilst not removed, and no one is suggesting obliterating the use of the word maternity services. So I think, and that was a long garbled way of saying, I think in answer to ask the questions, it requires leadership, and that means NHS England, Department of Health, Royal Colleges, you know, senior leaders, you know, need to set the scene and reassure those that have anxieties about this and move us towards more inclusive approach to language, so that people like Ash on the ground can challenge that and have the support from their organisations.
Thank you, Michael. It may be a longer answer, but I think every word worth it, because we know, you know, this is hotly, as Ash says, hotly contested on the ground, and we'll take leadership to make it work. What I'll do now is we'll talk a little bit about sexual health, but if you do have any more questions or fertilities or comments, please keep on getting those in. All the questions and comments will be taken away if I don't get to them, because obviously we do have a lot of participants here today, but we will try best to get to them. So Deborah, just wanted to come back to you, and there's a question here about the self-sampling HPV swabs for hard to reach groups, and just asking, after a pandemic, well, he said, where we've all got used to ramming swabs up our nose, is it getting more acceptable to do, you know, home testing? Is this something we can really look towards, I think, in the future?
Yeah, I mean, I think home sampling and home testing have been one of the real kind of success stories of HIV over the last few years, and there is absolutely, I think, a continued opportunity to really grow that. So, you know, I think one of the things that has led to the really significant decrease in the number of new cases of HIV has become, you know, how easy it is to test regularly without necessarily only having to do that by going to a sexual health clinic. So you can buy a self-test in a supermarket, do it at home, have your result within 20 minutes. Most, although not all, local authorities provide year-round access to home sampling kits for free, where you take a finger prick stick, send it off to the lab, get the result at home. And of course, the action plan itself is funding opt-out testing in emergency departments, which is a way of identifying HIV in people that maybe wouldn't think they're at risk, so may not be actively going out and testing. And it's also a way of identifying people who possibly have previously been diagnosed with HIV for various reasons, aren't engaging with care, and helping them to re-engage. So there's a lot of opportunities in terms of testing. And I agree with the kind of basis of the suggestion. I think it's been improving anyway, but, you know, one of the things for those of us working in HIV over the last 2 years, and I think public health in general, has been suddenly seeing all this stuff that felt very niche being discussed everywhere, and kind of familiarity with the idea of, you know, kind of infection and how that works and different types of transmission, and getting used, as you say, to testing. And I mean, an HIV test, I think, is a lot less unpleasant than sticking something down your throat or up your nose for a COVID test. So yes, I hope and I believe that it's helped to mean a real change in the way we think about testing. But now we have to grasp that opportunity and get information out about the need to test regularly and improve accessibility of tests. And then that in turn means that people know they have HIV, they can get the care that they need to live a normal and healthy life. And of course, they then eventually become undetectable, and it's a virtuous circle. They can't pass HIV on to anyone else.
I actually have another point to make on this that kind of spurred off something else that we've been thinking about, is when it comes to like smear tests and other tests that obviously require speculum, for particularly for lesbians, can be very painful procedure. We've done like a poll and stories on our Instagram, and we've had so many people come back and say they've had an absolutely horrendous experience when they've gone to have their smear test done. You know, they don't know, maybe they might need to ask for a smaller speculum, the nurse doesn't offer it, or check they might need a smaller speculum. And really, you know, your smear should not be painful. And unfortunately, we both experienced very painful ones. And that's just something that is really, I think, needs to be looked at. One, I think the speculum needs to be redesigned. So if there's someone out there that can redesign it, that would be nice, thank you. Because that's been in place as like pretty much was a torture device back in the day, which is nice. And then secondly, is just something simple I think we could do is have a cushion that raises you up. And this will be for artificial insemination as well. Because when I went for what's called a high cozy, when you have your tubes blocked, they were struggling with me, and you know, they said, "I'll put your hands under you, meant to put your hands under your bum, raise yourself up." But I have a disability, so this is not easy for me and not easy for everyone to do. And it just really frustrated me. And I was thinking, how can there not just be like a pillow that's the right shape for me to sit on? And so I just wanted to say that.
I really agree with what you're saying, and I think what you're talking about is actually just further evidence of the way in which women's health, and especially women's reproductive health, is not taken seriously, and often women's pain is not taken seriously. You know, so you're just expected to deal with something that, I've had the same experience as a lesbian, can be incredibly painful when it shouldn't be at all. And then you're told that it shouldn't be painful, so they don't really take it seriously when you say that it is.
Yeah, it's like, oh, just keep going, it'll be fine. I'm like,
yeah.
It's traumatizing for the both of us and the nurse involved.
Yes, we scarred the nurse up.
Yeah. No, I'm so with you.
Good, thank you.
Yeah, no, I had to agree, and yeah, I've got some also compelling testimonies on that, but they're probably not my stories to share today. But like you said, yeah, I think everybody on this call gets that, and perhaps how that relates into this conversation specifically. Just Deborah, sticking with you, we've got another question from Richard Angel from Terence Higgins Trust. He's said, with STIs disproportionately impacting gay and bisexual men who have sex with men, as well as bacterial STIs in the last 2 years, with bacterial STIs in the last 2 years being the most likely group to get a positive HIV diagnosis, what tech, automation, or improved communications channel can support more routine STI testing?
Oh my God, Richard, this is a really specific question. I might try and make Michael answer it, but sorry, go on. Emma, was that the end of the question?
That was the end of the question, yeah, sorry, I'll...
I mean, yeah. It's a good question, but I think when you get very specifically to the tech and things, do you want to come in first, Michael, and I'll add to it?
No, I was hoping that you might answer that. God bless Richard Angel. I'm wondering if to
come in himself, isn't he?
I'm wondering if tech or technology. I'm just trying to scroll to see if I can see the question. I'm wondering if tech or technology is talking about online testing, which I touched on before. I mean, I think certainly in my clinical experience and in the work that we've done at Terence Higgins Trust, we've long been advocates of online testing for STIs, not just HIV, and we found that in communities who are at high risk, who are not accessing traditional services, online testing for STIs or HIV, you know, where you go on and you order a kit and it gets sent home and you do it yourself, and then you either send it back, or for self-testing for HIV, you read it yourself. It is for some people and not for everybody. And there is, you know, you need to be aware of digital divide and whether people can, you know, have the devices or the Wi-Fi or the credit on their phone to access it. But anyway, for those for whom it is acceptable, it is very acceptable. And for those who may not live near a traditional face-to-face service, it is very acceptable. You know, if you live in the middle of rural Berkshire or Northumberland or Cornwall or anywhere, I don't know why I picked those, it can be difficult to get to a service that's not open very often and can be 50 or 100 miles away. You know, we're very fortunate if we live in London that, I mean, you know, you can walk from my sexual health service to the other one down the road at Guys and Thomas's. You know, it's a short tube ride between many services. So I think from a policy point of view, and also from a service provision, prevention and funding point of view, having moving us to a situation of equitable access for online testing for all STIs and HIV across the country would make a massive difference.
And maybe I can just add to that.
No,
sorry, Michael. Maybe I can just add to that I think there's something about, this certainly happens in some areas, but I don't think it's consistent, and especially when you're thinking about home testing, and is moving to a system where it is more standard, that the assumption is that you're testing across all STIs. So it's, for those kind of home things, there's often like a kit that tests for a range of STIs, and then a kit that tests for HIV, and it isn't necessarily automatic that you're testing across everything if you order one or the other type. So I think there's something about kind of trying to recognize that co-infection is an issue, that it's a way of identifying people and encouraging testing across both things and the same. It's great that the HIV testing is happening in emergency care, making sure that that's also testing for some of the other kind of STIs and bloodborne viruses. I don't know if that's what Richard was thinking about, but anyway.
I don't know, was it perhaps in terms of as well, alerts to phone alerts and things like this, perhaps?
Yeah, there's kind of things around reminders and...
yeah, I think it'd be remiss of me as well to say that I think there's a part to play for local councils and the GLA in there in campaigning for getting more people to test, and that's something that I'm trying to get the Mayor of London to do right now. But moving on to a question here we have from Catherine, and I'm going to try and ask this, Catherine, from reading this. So it says, we still don't have good data on STIs for women who have sex with women because they're mixed with women who have sex with men. It might be that women who have sex with, they're mixed with women who have sex with men and women. But it might be that women who have sex with men and women STI rates are much higher than for heterosexual women. I mean, is that a point on data that perhaps needs answering?
I think it is a point, and if I may, I might jump in. I use those acronyms all the time, and I know a lot of other people don't. So WESW is women who have sex exclusively with women, and WSMW is women who have sex with men and women. So it's essentially whether you exclusively have, if you're a woman who exclusively has sex with other women, or if you're a woman who has sex with men and women. And as people know who've heard me speak before, I'm forever banging on about data, and Catherine is absolutely right on that. We do collect this information in sexual health services, but it's not reported routinely. So very often when you get quarterly reports on the rates of STIs, they're broken down by heterosexual or men who have sex with men, but we don't get a further breakdown by, or certainly is not as much analysis, and therefore not as much focus on, as you said, women who have sex with women, whether they're exclusively having sex with women or bisexual women. And that is important because this goes back to, I think, comments that I've made before, and I think, Emma, you were talking about your experience of sex and relationships education, which is taught in a very heteronormative way, and actually sometimes even taught that gay women or bisexual women don't need to worry about STIs or aren't going to get HPV, so don't need to worry about cervical screening, which is obviously not true. And as I mentioned before, we certainly know that certainly for younger bisexual women, so WSMW, women who have sex with men and women, have higher rates of reported STIs, unplanned pregnancy, and poorer sexual health and higher risk sexual activity. So I think women who have sex with women and bisexual women are still an unacceptably invisible, perhaps is too strong a word, but they are a not seen and not focused on group when talking about sexual and reproductive health.
Thanks, Michael. And with that, I think what we'll do now is we'll come back and we'll do summing up again. I think we've been quite tidy on time. I know some people had to leave at 4 o'clock, but so I might be generous to say we can have a minute for summing up perhaps from each participant. So if we go in reverse order to how we started. So Whitney and Megan, I'll come to you first.
Thank you. Yeah, I think for us it is focusing on the inequality and discrimination and barriers in place, and ultimately looking at the unfair financial burden that is placed on the LGBTQ+ community. And I think if that can be eradicated, then it will lead to a lot of other things. Hopefully you could hear me. I think I hear some weird noise going off. I hope that came through. Perfect.
Nice and succinct. And Deborah, over to you.
what am I going to say? I think it's a leadership question. Like everything that we've talked about pretty much on this call from all of us is solvable with will and leadership. And so I'm going to say that and leave it there.
Great, and Michael, finally to you then.
Might try and steal two, so obviously completely agree with what everybody else says. So one of them is that point that I made about making sure that we link up education and healthcare and the importance of LGBT plus inclusive sex and relationships education. I could potentially be put out of work as a sexual health consultant if we gave all of our young people the knowledge and the information that they needed to navigate the kind of sex lives that they want in as safe as possible way. I think the other thing for me is remembering all of the acronyms in the LGBT plus umbrella. I think, and it's understandable, and I'm not going to argue against it. We have a very strong focus on gay and bisexual and other men who have sex with men for very good reasons and quite rightly, but we need to bring the other acronyms up to that same level of focus, the other letters in the acronym, if you like. So gay women, bisexual women, and particularly trans and non-binary people. So put that same level of focus that we put on the G in the, put it on the L and the B and the T and the plus.
Amazing, thank you, Michael. And so just to everybody that's in attendance as well, I just want to say this really is just one small part of the conversation. The research team will be contacting to ask for case studies, information, everything in the chat is going to go into the work here. So, apologies if it didn't get to your point, but there will be much more opportunity to make those points clear, though I do think from both sessions today, we've got a lot of really good points there. So thank you to our second panel today. That's been really great to hear. And so if you do want to get in touch, the best email address there, you can see, I think, has been put in the chat, but you can reply to info@chamberuk.com. But I think that's really it for me today. Just say that this is the first of 4 sessions. So if you do want to look up on what the other inquiry sessions are, perhaps you have colleagues or that may be interested in those, or yourself if relevant, and do come along and continue to shape this conversation. But for me, thank you for joining the health part of the LGBT Commission. And thank you to one last time to our panelists. You were fantastic, and thank you to our panelists in the first half. You were also superb, and thank you for everything you are doing, championing these causes and coming up with great solutions to the problems that LGBT plus communities are facing across the UK. So with that, I will thank you all, and thanks our guests for coming again.
Thank you all so much.
Thanks.
Bye.